Good evening, everyone, and thank you for joining us at our first Florida Orthopedic Institute live lecture series. My name is Jory, and I'm one of the physician liaisons here at FOI. I hope everyone's having a nice evening and preparing for the upcoming holidays. Tonight, I'm so proud to present Dr. Evan Loewy, one of our foot and ankle surgeons who is board certified by the American Board of Orthopedic Surgery, as well as a member of the American Academy of Orthopedic Surgeons, the American Orthopedic Foot and Ankle Society, and the Florida Orthopedic Society. Dr. Loewy is also an assistant professor of the orthopedic surgery at the University of South Florida. He sees patients at our North Tampa and our Brandon office. This evening, Dr. Loewy will be speaking about ankle arthritis. If you have any questions throughout the presentation, you can comment or ask directly on Zoom, and I'll be monitoring those questions. You can also send questions on our Instagram and Twitter at FL_ortho. At the end of the presentation, we'll get to as many of those questions as possible. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. And lastly, we'll be sending everyone a recorded link of the webinar in the following days. With that, I'm pleased to turn it over to today's speaker, Dr. Evan Loewy.
Thank you very much. So as you mentioned, my name is Evan Loewy. I'm a foot and ankle orthopedic surgeon. And today I'm going to be talking about something near and dear to my heart, something I'm passionate about, and that's ankle arthritis. So I have no disclosures relevant to this talk. So in terms of ankle arthritis, but just to briefly kind of go over the basics of what we're going to be talking about today, is very important for me for when we're going over something new with patients in terms of condition. I like to talk about the basics of that. And so we're on the same page in terms of why we're doing things and when and how and all of those types. But I think it's important for us to be on the same page for that so we can have an educated discussion. So briefly going to talk about various points of ankle arthritis. So just to start, this is a normal ankle x-ray, okay? So this is an AP and a lateral, so this is the front and side views. So this would be first if you're facing me, okay, in the x-ray, this is the inside part of the ankle, and that's the outside part. This is the tibia or the shin bone, okay? This is the fibula or that smaller bone on the outside of your ankle, and this is the talus or the bone that's underneath. So this is your actual ankle joint here. And then important points on the side view, this is the profile view of the ankle joint itself. And then the most important things I'm going to be referencing is joints underneath and in front of the ankle. So that's here and here. And then just briefly, on the inside part of the ankle, there's one ligament that has 4 components. That's called the deltoid ligament. And then on the outside part of the ankle or the lateral side, it's 3 separate ligaments. So that's here, here, and here. So a few things just talking about ankle arthritis, just kind of establishing this as an important condition. This is a study that looks at self-reported physical function in patients that have ankle arthritis, showing that it's equivalent to or worse than that of patients that have end-stage renal disease on dialysis, congestive heart failure, or cervical radiculopathy, or severe pain coming from the neck down the arm. So showing it's just as big of a problem for these patients as those significant conditions. This is looking at gait or walking mobility in patients that have ankle arthritis. And so it's comparing it to the patients on their other side or the normal or unaffected side. And this is showing that basically the ankle arthritis side has decreased motion, decreased strength, and decreased power. And it's showing that patients in terms of they have decreased steps per day and decreased gait and affected gait than population norms. And this study showed the average number of steps per day for patients with end-stage ankle arthritis is equivalent to that with patients with hip and knee arthritis. So I'll be referencing hip and knee arthritis. These are much more common conditions, and this is just showing that it's just as significant of a problem as those conditions on patients. This is looking at quality of life. So health-related quality of life. How much is this affecting your life in terms of the condition itself? So this is comparing patients with end-stage ankle arthritis, either going an ankle replacement or an ankle fusion, and comparing it to those patients that are going a hip replacement for hip arthritis. And so both of these groups of patients scored well below the population norms on all factors of this scale. And there's no difference between the two in terms of the physical component between patients with ankle arthritis and hip arthritis. And interestingly, patients with ankle arthritis actually scored worse on the mental component of this score compared to hip arthritis. So those are the reasons why we kind of established the baseline, saying it's just as important and just as significant and problematic as those more common conditions. Now we're going to talk about what I think makes it so interesting and challenging and what makes it unique. Why is it different from those other conditions? And so first, we're going to talk about the age. So the average age of patients undergoing hip or knee replacement for arthritis is 68. For ankle arthritis patients going fusion or replacement, it's 55. So this is a much younger patient population on average. We'll get into why that's the case, but not to say one group of patients is more important than the other, but it's different patients that have different part of their life, different expectations, different desires, and therefore it's something challenging in terms of treatment for those patients. Etiology. So the very common question is, all right, so I have this, but why do I have it? Where did it come from? And so with knee arthritis, the overwhelming majority of the time, probably close to 90%, if not higher, is primary osteoarthritis or just wear and tear. Then less than 10% of the time, it's post-traumatic, or meaning it's coming from an injury, either one big injury or multiple small injuries. The opposite is true for ankle arthritis. Majority of the time, 70, 80, sometimes 90% reported the rate is or the arthritis is coming from traumatic arthritis, or again, one big injury or multiple small injuries. Pretty uncommon in terms of less than 10% of the time, it's primary osteoarthritis or wear and tear. So this is showing us, okay, of those patients with post-traumatic ankle arthritis, well, specifically, what was the injury or injuries that led to it? And so this is showing about half the time, the central portion, the central bar, half the time it's from a malleolar fracture, basically just a common ankle fracture, okay? Ligament instability, so usually that's more multiple small injuries or recurrent sprains. It's about a fifth of the time, or 20%. And then pilon or talus fractures, 20% of the time. Those are basically bigger injuries, higher energy, so fall from height or car accidents. And then on the far side, you'll see basically years from that injury to needing ankle surgery for the arthritis. You can see in the ankle fractures, it's less significant of an injury, still significant, but about 25 years on average to needing the replacement. So arthritis continuously kind of getting worse and worse with time. Ligament instability is a little longer, and then pilon talus fractures 4 years on average from the injury needing a reconstruction surgery. It's much less common than hip and knee arthritis. I usually talk to patients. Most people that are coming to see me either have themselves or know someone in a direct family member or friend that, or multiple, that have had hip or knee replacements. Not many people even know that an ankle replacement's a thing. So knee arthritis is 8 to 10 times more common than ankle arthritis. So last year in the US, over 650,000 knee replacements were done. Surgeries for ankle arthritis, so either a fusion or replacement, less than 30,000. So significantly less common condition. And that brings with it very interesting challenges that we're going to get into. So knee arthritis is 10 times more common, but surgery is 22 times more common. So not only is it a more common problem, but surgery is being done. So why is less surgery being done for ankle arthritis? It's not a corresponding number. Something that makes it interesting as well is complexity of the cases. Okay, so only 37%, a little over a third of patients having surgery for ankle arthritis have normal alignment. So we'll get into that in a little bit, but basically the side-to-side motion, or if it's tilting, or if there's other issues from other fractures or things, only a third of them have normal alignment. Whereas the majority of the time in hip and knee replacements, it's normal alignment. Okay, so major adjunct procedures are needed in 35 to 40% of ankle arthritis cases. And that's really uncommonly needed in in hip and knee arthritis. And so one thing you'll hear me reference multiple times as we get more into this talk is sometimes we have to change the tires, or for instance, an ankle replacement, but a lot of times we also have to address the alignment. We can't just change the tires if we don't fix the alignment. Sometimes we have to do that at 2 different settings or 2 surgeries. Sometimes we can do it all at once. But again, more than half the time we have to address it in some capacity. So just kind of an example, we'll get more into this, but just to kind of show some basics of this, right? This is a case example, not super uncommon in the sense of patients that have arthritis. So this is an example of a patient, a 56-year-old female, had a triple arthrodesis, or a fusion of those joints that I mentioned below and in front of the ankle. So she had that as a child for a club foot. Now the way that they healed and the way her foot has moved around them, they're in bad position and they're causing her to have ankle arthritis with deformity there as well. So lots of things going on here that we have to consider when we're talking about treatment options. And so we'll get into that in a little bit, but here, next slide. So in terms of complexity as well, the post-operative course is very different, okay, in terms of expectations of what we'll be getting into. So after hip and knee replacements, many of you probably know, you can walk on the same day. You have very uncommon to have wound complications, or rare, for instance. You don't need a cast or a boot or brace anything after surgery. Pretty uncommon to need a reoperation. You start physical therapy day 1, and there's a lot of support programs and teaching programs out there. And then on the contrary, if we go to ankle surgery, so ankle replacement or fusion, usually either way, we're going to be no weight on your foot for 4 to 6 weeks after surgery. Skip down here. A lot of times you will need a cast, or you actually always will either need a splint and then a cast, typically again for that 4 to 6 weeks, and then probably a boot after that. there's a higher risk of reoperation than hip and knee arthritis. We'll get more into that, but not high, but higher. Can't start physical therapy until you're out of the boot and you start walking on it. It's much less common to have educational programs. And so one thing too, I want to get into in terms of wound complications, it's not necessarily way more common to have a wound problem, but as you could imagine, it's a bigger problem if you do have one. So if you imagine doing hip surgery on the side of your hip, if we have to go in and reclose the wound, there's more tissue there, and anybody, we can just push it together and get the wound closed. But on the front of your ankle, there's not really a whole lot of extra tissue there. So it can be a bigger problem if we do have a problem. So, okay, that's great. They're different, but what does that mean? So taking it all together, long story short, is it's just as big of a problem for patients as hip and knee replacements in terms of, or excuse me, hip and knee arthritis in terms of quality of life and health adjustment. It's probably a longer course of disease. These patients have that 40, 25, 30 years of this condition getting worse and worse, affecting them usually, as we said, average age at surgery is 55. So if we go 25 years back from that, the majority of your adult life, this is a significant problem for you and starts a lot earlier than hip and knee arthritis. And it's a lot less common, but it's more complex, and it's disproportionately less frequent from a surgical standpoint. So that's kind of play into a lot of these things as we go forward as well. Next slide, please. So again, I don't want to get too far into the weeds with this, but just generally speaking, this is a classification scheme for patients with ankle arthritis. So there's 4 types. The basics are type 1 is just straightforward ankle arthritis. The tires are worn out. There's no alignment issues. There's no other significant problems. And that's the most basic situation. Then we go, for instance, to a type 3. Those are patients with significant alignment issues in addition to their ankle arthritis. And then, for instance, type 4s, those are patients that have arthritis in the joints in front of or below, like we talked about before. The reason that's important, we'll get a little bit into it, but the reason that's important is because when you have an ankle fusion, it's actually not a peg leg, which most people would think. You actually have pretty decent motion still maintained through those joints in front of the ankle. And so most of the time, actually, if you have a patient that had an ankle fusion that's well done and healed well, and they're in sneakers walking down the street, you probably wouldn't be able to tell which side actually had surgery or not. But if that joint already has arthritis in it and it's not working properly to begin with, it's going to be more painful. So in the past, we used to think that patients that are further on the side 1, that are more basic cases, would probably be the ones for ankle replacements that are better suited for that. And people used to think, well, these big complex cases, the ankle replacement's even more complicated. We shouldn't do that. Let's just do it for the basic ones. Those complicated ones, we just got to do a fusion. What we're realizing is it's actually the opposite. Patients that have the straightforward cases are probably better actual candidates for ankle fusions. As you can imagine, if we fuse the joint, that's the ankle joint, it puts extra stress on those other joints. If they're already arthritic, like I said, then those are going to be problematic. We're just shifting the problem. But if we do a replacement, then maybe that's alleviated to some extent. So getting in terms of treatment options. So much like hip and knee arthritis, the mainstays are anti-inflammatories such as Aleve or Motrin, Advil, those types of things. And they do work well to some extent and for a period of time. Corticosteroid injections are certainly an option. They're not as common, for instance, in terms of knee arthritis, which they're really a mainstay of non-operative treatment. A lot of times because, like we talked about, a lot of times there's a bigger deformity or there's other problems. And so even if we can get the inflammation down temporarily, it's going to come right back because of those other issues, the alignment problems and so forth. So they may not be as good of an option or as good, as useful often, but we certainly do use them. Activity modification, that's our fancy way of saying if it hurts, don't do it. Bracing options I'll get into, those are possibilities. And then a rocker bottom shoe, I'll show an example, but if you imagine the ankle is arthritic and it's painful or decreased motion in that up and down plane, then if we can use a rocker bottom shoe that kind of takes some of that motion from your ankle, it can be a little bit more functional and take away some of the pain. And so the next slide is going to show us some awesome options for bracing. These are very high fashion, as you can see, easy to get on and off and very functional. That's not the case, but again, this is a rocker bottom type of shoe. There's newer versions out here. This is one of the classic kind of original ones. I remember the commercials, but there's newer kind of more fashionable options. But again, there's not a lot of tremendous options for these from a non-operative standpoint. Okay. And then once we start talking about operative options or surgery, how do we treat this with surgery? So there's 4 main ways of treating it. I'm going to focus on the top 2 because that's overwhelming majority of the time. That's what we use, especially in our patient populations. Those are the 2. So we're going to do a fusion or a replacement. And so first, we're going to talk about fusions. Next slide. So actually, sorry, briefly, this is just a graph. This is from a few years ago from a study that was done from Medicare patient populations. Basically, that top line is the amount of fusions that are done for ankle replacement. The bottom line is replacements. And so with time, those numbers are growing together. Again, there was a lot of hesitancy previously for doing replacements for multiple different reasons. But as we're getting better at them, the implants are getting better. We're learning how to do them and when to do them. Importantly, those numbers are coming closer together. And then next slide. And so this is one of the reasons why we can do them more often, and we're getting better at them now. And so this is a company that I use just in terms of, I think it's an interesting slide. It's a picture because it shows the different options that we have. So here, these are some of the options. Those are minimal resection, minimal, good bone, minimal deformity, younger patients usually, those are the options we can do. And the InBone, the one that's kind of second to the right, that's usually patients that don't have good bone or they have bigger deformity. That's what I use that. And then what's really important is the last one on the right, the biggest one there. That's called Envision. That's a revision system, meaning replacing a replacement. So this is a pretty new system that's available, and it's the first one really out there for ankles. It's important because a lot of times the biggest concern for people not wanting to do a replacement in the not so distant past is, okay, great, we replaced the ankle. Well, what happens when it goes bad? What do? We have a big hole and we don't have any other options. Well, now we can replace the replacement, and this is a huge advance for us, an option. And then on the far left side, these are called prophecy guides. So this is a 3D printed guide that we make that's custom for the patient. And so if we go into the next slide, this is an example of what I get. So we're going to do an ankle replacement. Typically we do a CT scan of your ankle, and then that's sent to the company, and they generate this program generates a guide or a plan for me, and we go through it and make sure it basically allows me to pick what implant I want to put in, exactly how and where I want to put it in. And then once we can confirm that, I know which size and exactly the positioning, it actually generates a 3D print, those little guides that I use during surgery to make sure I do your replacement surgery exactly how I want it to be done. So the way I kind of say is that the implants aren't custom, but the surgery is custom. So talking a little bit first, excuse me, about fusions. Okay, so the positives, everything's positives and negatives, and we have to weigh the risks and benefits. Okay, so the positives of an ankle fusion, it's got a great track record. It's the gold standard. We've been doing it for the longest amount of time. We have the most experience with it. It really is a great surgery when we need to do it. The union rate or the fusion success or the actual healing of it is 93 to 97%, which is pretty good. There's not really any activity restrictions, meaning once it heals, there's nothing that I'm going to tell you you're not allowed to do. There's maybe some things that you aren't able to do because it's fused, but you're allowed to go do everything, go crazy, run, jump out of airplanes, anything you want to do. And that's a good option for a lot of patients that are younger, and that may be a better option for them. The negatives are, like we kind of got into, is it puts extra stress on those other joints. And so those can wear out with time, which I'm going to show a little bit about. But then also, if they already have arthritis, it can affect the option because it'll make more pain there. And then, of course, even though it's good mechanics still, and I said it's pretty normal and do better than you may imagine, it's still not normal. So this is a couple of things, a few studies on ankle fusion, just to give you a little background. So this is a long-term study, and like most long-term studies in orthopedics, they come from Iowa. Take it for what you will, but that's where they come from. And 23 patients with post-traumatic arthritis that had no arthritis in the joints in front of or below. It's very important. They had zero arthritis in those other joints before surgery. Average age of fusion was 41, okay, very young patients. And the average follow-up is 22 years, which is pretty long for orthopedic studies, okay? And then if the next slide here, this is, again, a lot of numbers, but what I want you to focus on is the bottom box, okay, where the 0% are. That's looking at the patient's other foot in those joints in front of or below the ankle. Basically, at most recent follow-up, they never had it to begin with, and they still don't have arthritis in those joints on x-ray. And then the top box is the patients that had the same side that they had the ankle fusion. So 91% of them in the joint underneath the ankle developed arthritis on the x-ray. That's severe arthritis on x-ray. And then 56% of the ones in front. So they developed arthritis on x-ray. And then the next slide, again, tons of numbers, and I don't want you to get lost in the numbers, but just the important thing is the left side, the left box, this is ipsilateral. That means the side that they had the surgery, the fusion on, and then the contralateral is the other side, right? So lots of numbers, but most importantly, there's more big numbers on the left and a lot of zeros on the right. So that's basically just saying that's how much pain they had, essentially, how much disability they had in those from those joints. So the last slide said that they had arthritis a lot of the times on x-ray, and this is just showing that it's actually symptomatic arthritis. Okay. This is, I think, is really fascinating slide, fascinating information. So this is 28 patients that had ankle fusions that are highly satisfied. So they're all extremely ecstatic. They're very happy. They would do it again. They're happy with their outcome. This is looking at the number of those 28 patients and the percentage of patients that have difficulty with these different activities, right? Walking on uneven ground, almost 80% had trouble with that. 75% or 3 in 4 of them had trouble with stairs. Okay. 71% trouble with pedals, right? 36% had difficulty putting on boots. So you may look at this and say, wow, that sounds like a terrible surgery. These patients have a ton of trouble. I think it's the opposite. These are all patients that are extremely happy. This is showing you how good of a surgery that is. They have that big of a problem with basic activities of daily living, but they're still extremely happy with what happened because it's such a successful surgery for getting rid of pain. And that's what's important from an expectation standpoint when you talk about an ankle fusion. It's a salvage procedure. The number one goal is to get rid of pain. We're going to have to make some sacrifices to get rid of that pain, but sometimes that's a necessary evil. And then next slide. So now we're going to talk about replacements. So some of the stuff's the opposite, right? So better gait mechanics, we're still maintaining some of that motion in that joint, or maybe even restoring motion. And so then you're going to walk a little bit better. That in turn, we think, we can't necessarily say it definitively because we don't have long-term studies really that show it yet, but it makes sense to say that there's less arthritis in those joints in front of or below because we're maintaining motion. The negatives, like we talked about, higher complication rate or reoperation rate. So the Crocs, that's just a study that was done in Canada. A large study looked at comparing replacements and fusions. And so 30% of patients with replacements had reoperations and 14% of fusions had reoperations. Okay. That number with time, each time we have a study like that, that gap is narrowing. Again, as we have more repetitions, we have better implants, better technique, better indications, that number is narrowing. Okay. But sometimes that still is a true thing that we need to be aware of. And then next slide. So we're going to talk about a couple studies that we did, actually, that I was lucky enough to be a part of. But so this is actually the STAR. This is a specific type of ankle replacement. This is one of the original 3 that was released in the US. So we have the longest term data on it. And it's actually the only of those original 3 that are still available today. And so go to the next slide. Sorry about the formatting issue there, but basically this is a study that we did, actually did here when I was in training with one of my mentors on his patients. It was a part of the original study that was looking at the FDA study. We looked at these patients moving forward. Basically, how long do the implants last? How well are the patients doing? And then do they need reoperations? And so if you go to the next slide, just talks about, basically it was 140 patients. And at the time it was published a few years ago, it was the largest and longest term study from ankle replacements we had ever been published in the United States to date. And so with that, we showed that at 5 years, 90% of patients still have their original implant in place, 82% at 10 years, and 77% at 15 years. So that's when you say, okay, well, great, we'll do the replacement, but how long is it going to last? Am I going to need another surgery? So really to the date, this is the best long-term data we have. And it's certainly not where we want it to be, but it's certainly reasonable and getting better, we think, as implants get better. If you go to the next slide. So something that's really important that we got out of the study as well is, again, like I kind of alluded to earlier, one of the concerns was, okay, great, we do the replacement, but what happens when it goes south? Do we have a bigger problem than when we started with? So this showed we don't really think so, right? So this is what happens when patients have their failures. Okay, so we had to take out their replacement. What did we do with it? How do we manage it? So basically 80% of the time we were able to convert it to an ankle fusion or the surgery they would have had initially if we didn't do the replacement, or we did a revision replacement. So kept the replacement. So 80% of the time we were able to either do the same surgery or the one they would have had anyway. And those were successful surgeries. And this was, again, started in 1999 was the first surgery that was done for this study. And so as I mentioned, we've had this new revision system out. We have better techniques. So I would argue if we redid this today, it probably would be even greater number. So next, this is one that I mentioned earlier on the slide. This is one of the ones I use. And so this is called the InBone 2. And this was actually during my fellowship, we did a study. And additionally with that one, it was the largest and longest term study that for that specific implant that we had. And this implant, you can go to the next slide, this was 126 patients those first done in 2010, right? So that implant literally is only 11 years old. So we don't have long-term data on it. So some of the time we can't really answer exactly how long it's going to last. But this study showed us in 75% of those patients, so about half, we were able to get 5 years of follow-up. And the average age at surgery was about 62, so a little older than the average that I mentioned earlier, but nevertheless around the same time. And if we go to the next one, we looked again, same things. How long did it last? Did they need more surgery? And then the coronal plane deformities, if they had a big deformity or alignment issue, did it maintain that? And then if you go to the next one, shows basically that 5-year survival was about 92%. So a little bit higher than what we had for that other study. But again, We don't have the long-term study. We think that this is a better implant. Again, I can't say that definitively, but we think for multiple different reasons, I think it's a little bit better. Some would argue that, but nevertheless, we think we have better techniques, better technology. And again, so we think we're going to have a little better outcomes maybe even than before. Interestingly, too, with this, all of the failures for this one that we had, at least in this study, were within 2 years of surgery. And so a lot of you may hear me say, if you have seen me in clinic, that if you're doing well at 2 years, you're doing well at 10 years. And so we think that if you get past the first 2 years, is there going to be patients that had wound complications or other issues, infection, some of those things we don't like to have, but that can happen. Maybe it was not the perfect surgery or something didn't go well from those standpoints, still had pain from another source. Basically, all those patients, you get past the first 2 years, the alignment's great, everything's going to do good. We think you're going to continue to do well at least 10 years, if not after that. Additionally, an interesting thing from this study, only one of those failures that we had was actually really related to the implant itself. The other ones were those other issues that can happen with any surgery. And that was honestly also a technique issue. So we think this is a really good implant, and we're going to have to keep an eye on things moving forward, but we think we're getting better implant survival. Go to the next one. Just briefly, this is kind of showing that 84% of the patients in this study were either type 3 or type 4. So those bigger, badder, kind of more difficult cases, and they still did very well. And so that's why you could argue that even though the survival was the same, maybe these are harder patients. And so maybe then at the end of the day, it's technically better. But either way, we have good outcomes from this and good data moving forward. Go to the next one. So this is just actually a patient of mine. This is an example. This was actually called an agility replacement. This was one of the original 3 that came out with the star that I showed you, but this one's no longer on the market. And so this patient came in, had cysts, and kind of see here how that's lighter. Big cysts there, actually had a break in the bone, had pain, it's collapsing in the front, and had a lot of pain with this. And so this is one, if you go to the next one, we actually had to do 2 surgeries. So first had to take out that replacement, fill in that cyst with bone graft. You can see on the right x-ray there from the front, that's not as light as it was before, and then fuse the joint underneath the ankle and one in the front. And then if you go to the next one, we came back after that healed and then did a revision replacement. This is the revision or the InVision tailor component. And so patients doing well after surgery now at this point. And so sometimes, like I said, it has to be 2 surgeries, which isn't fun, but it's sometimes the best way to do it and get the best outcome. And then again, this is that first patient I showed you before. And then if you go to the next slide, what did we do for her? So we actually had to cut through the joints that were fused in the front and below and spin those to get them in better position to fix the alignment. Okay. And then once that healed, we came back. And then the next slide is showing the replacement that was done on top of that. So it really, these newer techniques, understanding better implants really opens the door and taking care of a lot of patients that had bad problems without a good answer. That now we can take care of them in a better way. So in conclusion, ankle arthritis is significant. It causes significant and similar problems and affects patients just as much as hip and knee arthritis. It usually occurs in younger patients, and it's actually more complex from a surgical management standpoint. And then next slide, please. An ankle fusion may offer lower reoperations in the short term, but we think that it's going to cause more problems in the long term, potentially with the adjacent joint arthritis. And ankle replacements are becoming more reliable and a more common treatment option. We think that ankle replacement failure management may be more approachable than we originally thought, and newer implant designs are offering promise for expanded indications and able to take care of more patients. Thank you very much. This is a picture I got when I was in clinic one day from my wife and kids asking to send help. So may feeling this way after seeing all those pictures and the information.
Well, thank you so much, Dr. Loewy. That was a great presentation, very informative and helpful for anyone who may be suffering from ankle pains. So now we've got some time for a few questions that have been submitted. Without further ado, I have a couple right in front of me. So a patient asked, in the morning when I first get out of bed, there's a tightness or stiffness around my ankle. Are there any stretches I can perform to reduce the tightness?
That's a great question. Yeah, and that can be from a lot of issues. Sometimes it can be from arthritis. A lot of times in the morning when you get first moving, it's the stiffness there, and you got to get lubricated up and get the oil flowing. So basic stretches. I mean, kind of the classic ones in terms of just kind of bending the ankle back, using a belt or a towel or rope kind of around the ball of the foot. Usually recommend doing that with the knee straight, kind of foot still on the bed, and then just kind of in and out, basically all directions. I mean, nothing necessarily specific with that, but I think it certainly is a good option to get things moving.
Nice. And between non-operative and having surgery, how are you able to determine if surgery is needed if the ankle is between a type 2 and type 3 classification?
That's a great question. With me, surgery, the way I always tell patients is that, I'm a surgeon. I love doing surgeries. We talked about surgeries, but, if you ask me, when should I do surgery? And a lot of times I'll tell you, you'll know, right? So surgery is the last resort. We have options, but we always want to wait as long as possible. Things can happen with surgery. At the end of the day, I treat patients just like I would a family member. And I'll tell you the same thing in clinic and say, hey, you're going to come in and tell me that maybe today, that may be in a year, maybe in 5 years, but you're gonna say, I can't deal with this anymore. We've tried all this other stuff. And it just isn't working anymore. So more so it's, those types and the stages are more so kind of guide research more than anything and discussion and can say, maybe which type of surgery, but not necessarily when to do surgery.
Okay. And after an ankle fusion, how long is the recovery process? And will I be able to regain ankle movement up to 100%?
So the typical protocol or kind of post-op recovery from an ankle fusion, you're no weight on it at all for 6 weeks. Then you're in a boot for 6 weeks. And so then at 3 months, you're going into a regular shoe and starting activities. Usually tell patients full recovery. So you're starting to feel like it's behind you, like you're over it, depending on the situation, somewhere between 6 months and a year, potentially. There's just swelling, can take a long time to get better. And then getting motion back and activity. So you don't gain motion back at the ankle, obviously, because we're fusing it. But you certainly still have motion through those joints across the front. It's usually, again, more from a functional standpoint in terms of walking, like in a sneaker or something. Certainly barefooted it's not normal again, but one of those things that I sacrifice in terms of, I've actually had, interestingly, shortly after I started, had a patient came in that was sent to me by a primary care doctor because they came in and seeing them for the first time and they saw in their history that they had an ankle fusion in the past. And then when they examined them, they were like, oh my gosh, something's terribly wrong. Your ankle still moves. And so they came to me just saying, hey, something's wrong with my ankle. It's not healed. And so we got the x-ray and it was completely healed. But that's, it's a good example of it's surprising how much motion you do actually have. Again, it's not normal, but it's not a peg leg like you may think. And then again, kind of a little bit what you talked about in terms of getting back to activities. Like I said, the good thing about the fusion is once you have it, I'm not going to tell you can't do X, Y, or Z, where I may tell you that for replacement, for instance, generally want to avoid high impact activities. If you're playing tennis, maybe doubles tennis versus singles tennis, or maybe pickleball, which is big here down in this area, but versus a fusion, I'll say, man, if you can do it, just go for it. You just live it up. So that's why I kind of classically, for instance, like a construction worker or heavy labor or something, a replacement, or excuse me, a fusion is a better option. But basically once it's healed, you start progressing activities and go from there.
Awesome. Well, it looks to be all the questions we currently have. Well, thank you so much, Dr. Loewy, for your time and for this presentation. It was very informative. And thank you, everyone, for joining us. And we look forward to seeing you at our next lectures. Happy holidays from Florida Orthopedic Institute, and good night.
Thank you.